rahmatullahi wa barakatuh. Good evening, welcome everybody. On behalf of all SASPGAM members, who are now more than 140 members from Saudi Arabia and also from the Gulf countries, I warmly welcome Professor Anil Dhawan. Anil actually is a very close and true friend of mine. He was my mentor in 2004 when I did part of my fellowship training in pediatric hepatology in the pediatric liver unit in King's College Hospital, which is a great center to train in pediatric hepatology. He was very supportive to me during that time. He granted me the privileges of doing some research projects that I'm still really proud of. It was really a beautiful and memorable period in my life. So before I transfer the microphone to my colleague, Dr. Mohammed Al-Idrisi, I would like to extend my appreciation and thanks to Sobi Company for its generous funding of this webinar, and also to the eveint troops hosting this webinar through Zoom. Thank you very much, and Mohammed, the microphone is yours now.
Thank you, Abdurrahman. First, I'd like to really thank the audience who registered and joining us in this webinar. So assalamu alaikum and good evening. And I hope it will be an exciting and a very useful webinar about Wilson disease. And I'm really pleased, to welcome Professor Anil Dhawan, who's our special guest, speaker for tonight. He's at King's College, and as Abdurrahman said, probably the generation, I think, Abdurrahman, you are still young, but my generation, the old ones, we used to see Anil all the time around since we were, so we grew up actually knowing Anil actually as a very resourceful person in pediatric hepatology. Professor Anil Dhawan, he's a professor of pediatric hepatology at King's College Hospital. He's currently the director of research and innovation, and also he's director of pediatric GI and nutrition center at Mowat Labs. I really have to tell you, I had a hard time to memorize the 72 pages for Anil's, biography. So I really tried to do my best to summarize it. He had more than 300 publications. He authored and co-authored actually more than 20 books and chapters. And I tell you, among his publications, there are at least 13 or 14 papers about Wilson disease. A lot of them are very recent and very impressive actually, and very, I think, very useful for the audience to refer to eventually. And I'm sure Professor Anil Dhawan, will elaborate on some of his good work that he did. All of us knew also Professor Anil Dhawan as part of committees that from North America and Europe, decision-making committees, and creating guidelines, and also a lot of the good work that was published, and we are following in our diagnosis, treatment, and follow-up of Wilson comes from these committees. So I don't know really what to say. He has been honored, awards and several international and UK awards. And whatever I say, I'm missing a lot of Anil's actually good work. But without delay, Professor Anil Dhawan, please, the floor is yours, and the audience, I'm sure they are very interested to hear, from you about Wilson and treatment and other management issues also. Please go ahead, Professor Dhawan.
Thank you, everybody. Can you hear me? Can you hear me?
Yes. Yes.
Yes. Okay. So, Abdul Rahman, first of all, you are such a generous person and kind person to say that, that I looked after you. I think you were one of the very extraordinary people who wanted to do research in a very short time that you had with us when you came from Canada, and you wrote the original paper. So credit is yours. We get the credit in the background, but you did all the work. So I'm very grateful to you to publish that work. I also know that how fantastically you are doing in Saudi Arabia, and your promotions and everything. So in a way, I'm very proud of you to see your journey and getting you mature and be very influential in the field of liver disease and gastroenterology. Mohammed Idrisi, you may remember I visited you about maybe 15 years back with my wife. We were in Dammam for a few days, and you showed us around Saudi Aramco, and I remember that trip in the car. And you have been looking after a very, very difficult patient of ours. And I have been in touch with you for many times, and so many other friends also. So to me, it's an opportunity and an honor, because a lot of work has come from your part of the world on Wilson disease. So I won't be doing justice because I cannot include every single thing, but obviously I will be very happy to discuss it when we have the discussion. So Mustafa, if you could have the first slide, please. So next one, please. This is, I don't know whether it has changed, King's College when you were there before, but that was the new King's College. And this slide is important because this is the gentleman called Sammuel Kinnier Wilson. He worked at King's College Hospital. And this is the old King's College Hospital, which completes 150 years of this establishment. And Kinnier Wilson was in 1920s. He was a consultant and initial registrar in the neurology ward of King's. And we have named a ward after him called Kinnier Wilson Ward in King's College Hospital. So there is a bit of historical link to Wilson disease at King's College Hospital. Next slide, please. Now, last few years has been very productive for the field of Wilson disease, mainly because last year, it was a centenary 25 years of the discovery of the Wilson gene. So that was celebrated. North American Society did it, Espegan did it, and there was 2 societies of North American and European Society of Wilson disease. They had special 2-day seminars. And in the last 3 years, we have come out with the guidelines from Espegan, Indian Society of Pediatric Gastroenterology. And as we speak, American Association of Study of Liver Disease is revising its guidelines, which we had the first 2 meetings last year. And the manuscript is going towards hepatology in the next few months. Next slide, please. Can I have next? Yeah. So I'm sure you're all very senior people, but I like to bring physiology into discussion. And I just want to discuss what does copper mean to us and how do we handle it. So this is a diagram of a liver cell. What you find there's a Golgi apparatus there. And in the Golgi apparatus, what we are finding is ATP7B gene, which is on the surface of it. The next slide, please. Click the next button. So this is what is ATOX1. ATOX1 is an antitoxin. So it is a molecule which is a protein which will take anything which is going to be toxic to the liver cells, and that is mainly the metals. So it's a metal chaperone. It's very important because copper is quite toxic, and copper, when it enters into any human cell, will cause a lot of oxidant damage. So it has to be carefully looked after. So this ATOX1, which is a metallochaperone, will take it into ATP7B on the surface of the cell endoplasmic reticulum and take it inside it. So if you click the next slide, you will see that copper molecule, next slide, please. The copper molecule will go into the endoplasmic reticulum. And what it will do is, in the apoceruloplasmin, it will take copper into it and become what we call as holoceruloplasmin. That holoceruloplasmin will go out into the plasma. So that is what we see. So hence, it's important observation here, ceruloplasmin levels are low in Wilson disease. It has nothing to do with ceruloplasmin metabolism. As you know, ceruloplasmin is synthesized in the chromosome 3, which is nowhere near Wilson disease. The ceruloplasmin is low because what we measure in the blood is a holoceruloplasmin, whole ceruloplasmin, which is a apoceruloplasmin combined with a copper molecule. So that is why we see it low. The second function here is that this copper is packaged into vesicles, which you see on the top hand side, and those vesicles are copper takes into the biliary tree and excreted into the bile. So the most important source of excretion of copper is the bile. The copper in the cell, which is not shown here, is utilized to make important proteins, albumin, and certain other metabolites that are other proteins that require copper, enzymes. So copper is used for, in a way, the fate of a copper molecule. If you see entering from the top left-hand corner into the cell, is chaperoned by the ATOX1 molecule into the Golgi apparatus or into the vesicle. So to do either to make ceruloplasmin, to contain the copper, and to excrete the copper and use some of the copper for cell metabolism. Next slide. So if you see now, if you have a problem with ATP7B, so copper has come to the cell, ATOX molecule has chaperoned it, but it cannot go incorporate into the ceruloplasmin. It cannot go into the vesicles, so it cannot be excreted. So if the copper cannot be excreted, so what is going to happen is copper is going to accumulate in the copper liver cells and ultimately go into the blood and will go into the all over the places. So hence you see lower copper excretion in the stool in Wilson disease because there is no copper coming into the bile, and the low ceruloplasmin because ceruloplasmin is not formed from apoceruloplasmin. Next slide. So because of that copper, so it's a very simplistic explanation that you got accumulation of copper in the liver, in the brain, in the eyes, and rarely into the heart, into the joints, and into the, what you see is the KF ring, which you see the right, the upper one. What you see here is the brown pigment, which is deposited. It's like a concentric ring. If it's quite advanced, you can see by naked eye. The slide below is a cataract. It's a sunflower cataract. That's also a copper deposition into the lens. It's uncommon, but it's one of the recognized complications of Wilson disease. Next slide. So now we know that Wilson disease is a genetic defect of copper incorporation into ceruloplasmin and excretion into the biliary tree because of lack of this ATP7B mutations. Now, we also know that Wilson disease presents with various presentations with liver disease, asymptomatic liver failure, neurological Wilson. Pediatric Wilson is mainly hepatological Wilson, and our median age of presentation is about 12 years. But anything beyond age of 4 or 3, these days, anybody comes to us with liver disease, we investigate them for Wilson disease. It used to be 5 years in the past. I think people have started, have reported some younger cases. Hence, in our institution, anybody above the age of 3 will get investigated for Wilson disease also. Having said that, we haven't found many, but in the family screening, yes, you can find, and we can discuss the management of those who are diagnosed on family screening at a very young age. So the question comes, how do we diagnose Wilson disease? And these are the list of the tests or the observations that can help us. Urine copper, serum copper, ceruloplasmin, KF rings, liver copper, hemolytic anemia, which is Coombs negative, other biochemical indices, and molecular diagnostics. So let's inspect every one of them. What is their value, how good they are in the diagnosis of Wilson disease. Next slide, please. So if you look at serum copper, unfortunately, has no value in the diagnosis of Wilson disease. It could be high, it could be low, it could be normal. So we will not test for serum copper to diagnose Wilson disease. It gets done as a part of the protocol, hence we find that it's high, it could be low also. But free copper is usually high in patients who have got an acute presentation because that's released, and you find in fulminant hepatic failure, it's in excess of 200 microgram per deciliter. Next slide, please. So I think the important molecule that is helpful in the diagnosis of Wilson disease is ceruloplasmin. And many studies have done, and we keep revisiting it, but we all agree that low ceruloplasmin below 20 milligram per deciliter is seen in about 95% of patients. However, it could be false negative. That means patient may still have Wilson disease, but ceruloplasmin may not be low, and that are infections because it is an acute phase reactant in pregnant females and estrogen states. So that is, we have to keep in mind that you can have low ceruloplasmin, normal ceruloplasmin, but patient could still have Wilson disease. Likewise, you can have a high low ceruloplasmin, but patient does not have Wilson disease. So 20% of heterozygotes with Wilson disease will have low ceruloplasmin. If the patient is suffering from protein-losing enteropathy, very rarely conditions like aceruloplasminemia and severe hepatic insufficiency, because ceruloplasmin is synthesized in the liver. If liver is very severely damaged, then the ceruloplasmin level may be low, not because of Wilson disease, but because of the synthetic failure. There are two methods of assessing ceruloplasmin. One is oxidative assay, which is more accurate than nephelometric assay. But these important things come when you are really struggling and a research methodology to compare. But in the general practice, if your lab is doing one or the other, they have experience on it, I wouldn't ask them to change it. Next slide, please. So we did some work and we reevaluated. So you may remember we published a study in 1985 about penicillamine challenge, we called it, and we wanted to revisit in 2006 what was the status of urinary copper estimation in patients with Wilson disease. So in this study, we had 38 patients prospectively, and we had 60 controls. The 60 controls are not normal people, but they are patients who are presenting to us with liver disease. So some of you have visited King's, we will remember that we do in our chronic liver disease workup, we include copper all the time, urinary copper and penicillamine challenge, even in patients who very likely are autoimmune, but they still get it done. So that gives us some data. So what we found is the basal urinary copper 24 hours, if it's more than 1.1 micromole per 24 hours, it was present in 97% of Wilson disease patients, but 30% of non-Wilson disease patients also had high baseline copper. And these are the patients you will see in your practice, those who have a cholestatic disorder. So if you have a various degree of cholestasis, they tend to have a higher copper excretion. Post-penicillamine or penicillamine challenge 24-hour urinary copper, that's more than 5 micromoles per 24 hours, was seen in 76%, while only seen in 7% of the controls. So that there was some discriminatory value of penicillamine challenge against the baseline copper. So it could be of benefit. It's not essential, but it could be an additional test if you would like to do. Suppose your patient falls into this category of 30%, and you say, well, no, I don't believe it, then you can do a penicillamine challenge that may bring it down to 7%. Next slide, please. So liver copper. So liver copper for a long time has stayed a kind of a very important feature in the diagnosis of Wilson disease. And historically, we have taken a value of 250 micrograms per gram of dry weight as compatible with liver copper. But you have to remember, like conditions like Indian childhood cirrhosis or conditions like sclerosing cholangitis also have a very high copper in the liver. So you have to remember. And second is there is a sampling error with the liver biopsy, which I will allude a bit more in the next slide. Next slide, please. So in this study, this is Peter Franchi. He looked at 114 Wilson disease, 219 other liver disease, and 26 no liver disease. And he looked at 250 as a cutoff, and he found that 83% of Wilson disease patients did fulfill criteria of 250 micrograms, while only a small percentage, 1.4% in his study, showed higher copper levels. So what we believe is that anything below 25 to 50, we start to question the diagnosis of Wilson disease. Next slide, please. Now, it's important in this slide. What you find is that these are the real scattergrams of the various people. So if you look at normal children, normal people have a value of less than 50. If you have other liver disease, NAFLD, alcoholic steatohepatitis can go up to higher. There are no patients in this study with sclerosing cholangitis. Otherwise, they tend to have a very high copper levels in the biopsies. But if you look at the Wilson disease, they are always going more than 250. So they are going up to 500 or 250 plus 500. But the caveat is that if you look at the liver biopsy I'm showing you down there, there's a lot of fibrosis in there. So if your biopsy is not representing parenchymal tissue, you may falsely have a low levels of copper as well. So you have to be careful that how much biopsy tissue and parenchyma is there. Next slide, please. So if you look at the molecular studies. Now, I think what has happened in the last 25 years since the gene was identified, we all have moved towards mutational analysis. But now, mutational analysis availability is not instant, and patients want a diagnosis as soon as they can. And sometimes it's important to start the treatment. But nonetheless, mutational analysis has become one of the most important diagnostic parameters for the diagnosis of Wilson disease. Next slide, please. As I described, the gene was identified something in 1993-94. There were 3 Lancet papers, one-to-one, not Lancet, they are Nature papers, one after the other, in the same issue where the 2 groups described the gene simultaneously. So it's a autosomal recessive condition. Most common mutation in the Western world is H1069. And but the problem is there is a variable penetrance, and most of our patients are not homozygous, they are compound heterozygous. So they do have 2 disease-causing mutations rather than 1 disease-causing mutation on both the alleles. Okay. We also don't know that what other gene modifiers are there that make the presentation of Wilson disease sometime at the age of 5, sometime at the age of 50, and sometimes at the age of 80. And the reason I'm insisting, pressing on this issue is that there was a paper, this lady was 80 years old, 83. She was admitted in New York hospital and with some other problem. And it so happened then there was a doctor who was on call that weekend, happened to be a liver doctor. He found her liver tests were mildly abnormal and he ordered Wilson disease test. And they found she was homozygous for 2 disease-causing mutations. So she has lived her age of her 80s, but never had any problems. So we have to be careful that mutational analysis itself is not everything. So we have to put rest of the thing into context as well. Next slide, please. So this is next slide. This is data from Hartmut Schmidt. We collaborated with him in Germany, who ran some tests for us for the research. Next slide. So this this slide shows the worldwide. So his lab has a data sample sent from rest of the world, and this gives you a flavor of what countries have what kind of a common mutations. Next slide, please. If you can click on these slides, it will show the. If you click on these, please. Yeah. So this will the United Kingdom on one side, Germany, Poland, Brazil, Egypt, and China. So what you find is H1069 is a predominant mutation in Germany, Poland, Austria. But if you look at China, it's R778. If you look at Egypt, it's 373. And in UK, we didn't have any predominant mutations. They were all a mixture of it. So we didn't have one H1069 predominant. But I like to remind you that UK is quite a diverse population. So we have a significant number of people from the Indian subcontinent and Middle Eastern. Hence, I think they are non-representing as a Caucasian population. That may be one reason. Next slide. Next slide, please. Now, this is a pediatric paper. And I think this paper, what it wants to emphasize is that these 3 patients had no really classical features of Wilson disease. I will talk to you about Frenchy or the Leipzig score that we described in late 2000. So what they are impressing on this thing is that if they didn't do genetic mutations on these patients, these people will not have a diagnosis of Wilson disease made. But you also have to remember that just having a genetic mutation without having other pathological features shouldn't make you think that without you start with the treatment without having any liver abnormalities or other signs of Wilson disease. Next slide, please. So in early, I think it was 2001 when we met in Leipzig, and it was a big meeting. Anybody with Wilson disease was there. Patients were there as well. And after that meeting, we come up with a score called Leipzig Score. Next slide, please. And Leipzig Score is based on next parameters that I will show in the next slide. But if the score is more than 4, the diagnosis of Wilson disease is unquestionable. 2 to 3, Wilson is likely. 0 to 1, Wilson disease is unlikely. Next slide, please. So if you next slide, Mustafa. So we did this score and we evaluated in children in 2005. So we had 70 patients in this, and we evaluated and we looked and we found that this score of 4 had a very high sensitivity and specificity of 94%. So we think this score is worth it, though it wasn't validated when it came, but when we validated it retrospectively in our patients, it stood the test of time. Next slide, please. So once you have diagnosed a patient with Wilson disease based on ceruloplasmin, urinary copper, penicillamine if you want to do it, KF rings, liver histology or mutations, and then what are the treatment options? Next slide, please. So let's look at the history of how the treatment has come. The disease was described in 1912. It was called as progressive lenticular degeneration. That's called Kinnier-Wilson. But copper hypothesis didn't come till 1948. I think Kinnier-Wilson was not able to put them together. He described the abnormalities in the liver and the brain, but he wasn't able to say that it's related to copper. There was suspicion, but it wasn't proven. So Cummings came with the hypothesis that there is a copper, and they use the drug British anti-leucide. So it's a heavy metal binding. It was used in the World War First and the Second for as a mustard gas, anti-mustard gas agent, and it's an injectable drug, and it's again a chelator, but it's intramuscular injection. It's quite painful. I have once used it in my practice when I was in India, but it's not any drug that anybody would like to do anymore. The real drug that came out was in 1956, which was described by Dr. Walsh from UCL and Cambridge. 1961 was zinc was introduced by Schoenig from Holland. 1969 was trientine, again by Walsh. Then transplantation in 1971. 1990 saw tetrathiamolybdate, and later on in the talk, I will talk about experimental therapies. Next slide. Let's look at a little bit how copper metabolism happens and what is the mechanism of action of every drug. So we eat in a normal diet about 2.5 to 3 milligrams of copper a day. And that copper goes into the intestine. Most of it's absorbed and goes into the portal vein. And if you look at in the portal vein blood, it will go into the liver. In the liver, it will taken up by the ATOX1 chaperone, put into the vesicles for excretion into the biliary tree or into ceruloplasmin. So the tissue, the enzymes that are dependent on copper are superoxide dismutase. There is a tyrosine metabolism which is required. There is cytochrome C oxidase and lysine oxidase. So these enzymes depend on copper. And in the copper deficiency, you will have a deficiency of these enzymes and symptoms because of that. From the blood, the unexcreted copper will come into kidneys, and that's why we see copper in the kidneys. Nor in the urine, normally less than 70 microgram per day is lost. So if you look at the areas that you can act on copper is, first is the intestine. Can you reduce the absorption of copper? And that is what zinc is doing. That is what tetrathiamolybdate is doing. So what they do is there is an upregulation of metallothioneins, and they reduce the excretion of copper. So reduced absorption of copper. So that's the first defense. Then you go into the liver, and then what D-penicillamine, trientine are doing, they are making these complexes which are not toxic to the free copper, and then they're excreted in the urine as a free copper. Zinc also has some action in the liver, so is tetrathiamolybdate. Tetrathiamolybdate is believed to act as ATOX1 as well, which is not proven yet, but there is a suspicion that it acts there. There are a lot of studies on D-penicillamine, trientine, zinc. I will show you some, but trientine, tetrathiamolybdate has just come in. Phase 2 study has just been published in adults, and there is a trial just launched in children also that will include children going forward with tetrathiamolybdate. Next slide, please. So here is the problem in Wilson disease. Wilson disease is a disease which is run by eminence, not by evidence. And this is a terrible thing to say in 21st century, but a lot of the experience is eminence-based, means people like John Walsh. John Walsh is an accomplished physician, He has described 2 drugs or 3 drugs, but he has not made a single penny out of it. If anybody does it today, they will be multimillionaires. He has not done that. He has truly looked into patient benefits. So look into this title. It says penicillamine, the treatment of first choice for patients with Wilson disease. You also note that the journal is called Movement Disorders, 1999, July 14. Okay, the next slide. This is the same journal, Movement Disorders, 1999, July the 14th, and see what it says. Penicillamine should not be used as initial therapy in Wilson disease. That's George Brewer. George Brewer is an adult neurologist and internal medicine, but he's a predominantly neurologist, and he has a different view. And he thinks penicillamine should not be used, but I will give you some data to show that hepatic Wilson, definitely penicillamine is beneficial. Neurological Wilson, there may be an argument, which I don't have much experience, but when I meet with these people, they are poles apart. There are one definitely fixed on other, the other is fixed on the other drug. So you have to be careful when you read the papers. Just be mindful that there's lots of personal bias from these historical giants who did a lot of work in Wilson disease. Next slide, please. So if I give you some data, we looked at 57 patients and we have followed them up to 40 years now, because we have a shared service, which I will show you adult and pediatric, how important it is, and what do you find in the long run, which you don't see in the short term. So if you look at this 35 males age, median age was what, 11.9, youngest was 5.9, 33 alive on chelation, 15 died at presentation, 10 transplanted. So these are the era when the transplantation was not routinely available. Next slide. Next slide, please. So if you can go to the next slide. So our treatment protocol is penicillamine 5 milligram per kilo per day. We increase the maximum to 20 over 2 to 3 weeks. And the word I will say is start low and go slow. That is the word. Don't be in a hurry to increase the dose or go maximum, because you cause complications. Trientine, we start also again low. Over 3 weeks, we get up to maximum 20 milligrams. Zinc, our experience is very, very limited. We have very few patients. We have a zinc and additional therapy. I will come to Leipzig Score. That's when we use additional zinc. But as a primary therapy, we don't recommend this. We have only 2 patients at the moment. And liver transplant for fulminant liver failure. Next slide, please. Next slide. So out of this is interesting, important data for you to remember. If you get a patient started on chelation and they take it, you will not lose a patient. So we only lost 2 children who stopped taking their medicine, and one was from Saudi Arabia. So they stopped their medication because that patient went into the desert and didn't come back to collect the medication. So if they take the medication, it will be very, very uncommon for them to die of liver disease or liver failure. Next slide. Next slide. So trientine, we have used it in about 17 patients and we have added 7, so there are 24 now. We only use it as a second line drug. When we have problems with penicillamine, mean proteinuria, arthritis, hematuria, bone marrow suppression, you need to have a significant complication to prescribe this drug. We can't just prescribe it because we like it. Lately, what has happened is the cost of penicillin has hit the roof. So it's tens of thousands per year rather than few hundred pounds we used to have on this. Hence, government asked us to set up a working committee in UK, and I represented pediatrics on that committee. And we have a certain guidelines now who can have trientine. So only 7 centers in UK are allowed to prescribe it, and it has to go through somebody like myself if a patient has to be prescribed trientine. Indirectly, what government is trying to do is not make it easy to prescribe, and not everybody has it because the costs are very, very high. But drug is very good, it works, and I will show you data later on from adults also. It's as good as trientine. There is some data to show that toxicity may be lower, but we will only use this drug when we have a penicillamine toxicity. We don't use it as a primary drug, and it's not licensed either. Next slide, please. So zinc monotherapy, I think some people believe in it. There are publications on it. We haven't. And this is a paper I want to share with you. This came in gastroenterology. 288 patients, median follow-up of 17 years. 68% were hepatic Wilson, 34% neurological Wilson. So 14 out of 88 had a treatment failure. So that is about 25–30% failure rate. So I don't think you would like to prescribe a drug that has that high failure rate. So this is very important. Next slide. If you look at adherence to treatment, so the first big black line is chelation. Then there is a zinc in the red, and then there is a combination of the two. So adherence to treatment, when you start more than 1 or 2 drugs, the patient's adherence becomes a problem. And also zinc has a lot of GI side effects, a lot of gastritis they cause, and then people start not taking it because it makes them sick. Okay, next slide. Then discontinuation because of adverse incidents. So there are more people who stopped zinc than penicillamine. So if you look at zinc is the red one, and the penicillamine continues to go down, zinc versus penicillamine. So the trientine adverse incident, sorry, let me rephrase it. So they didn't stop it, but they didn't take it. Sorry, that's what I'm saying. But if you have a combination, then there was a more discontinuation than a single zinc. Next slide. And this is discontinuation to treatment failure, which is important. So if you see the zinc has more treatment failure compared to either the combination or itself. So the take home message is, if you are going to use zinc as the only drug, be prepared that the side effects are going to be high and patients may not like it. Next slide. This is again, death due to liver transplant or death. So this was more in zinc rather than other 2 drugs. Next slide. Now, this is another observation. So this is a Dutch study. It looks at children, people with hepatic disease and neurological disease. And this is a non-ceruloplasmin bound copper in the blood. And you see how erratic the copper levels are in the blood when they are on zinc. On neurological, on the hepatic side, which on the left side, there is a more abnormalities, peaks of the copper. Compared to neurological patients do better on zinc only, but in liver ones do not. Next slide, please. So to conclude from my side, I think chelation-based therapy for hepatic Wilson disease are the best. Zinc therapy, you could consider if you believe in it. We don't do it here, but we can discuss in the discussion which will be the right patient for zinc monotherapy. Diet, I think we avoid a very high copper diet, but we don't ask them to restrict day-to-day life. And pregnancy, some people believe in reducing the dose, but by and large, their experiences don't change many things because you may cause problems. Next slide, please. So what I'm going to come to now is 2 aspects of this disease. One is the acute liver failure, and next is what is the long-term management. I think what we have learned over 40 years is the treatment is multidisciplinary. So we need to involve therapists, hepatologists, neurologists, psychologists to look after a patient with Wilson disease. So now we have a specialist Wilson disease clinic, which is attended by a neurologist, a psychologist, and a dietitian when they need them. And that I will show you the data, which is under publication at the moment, but it's very impressive data that we have found, which I'll show in the end of the presentation. Next slide. So in practically, what do we do? Once the patient are stabilized, then we get them every 6 to 12 months. They can get everybody gets a 6 months blood test. But if they are far away, then they can go to a local hospital and they can send the results to us. But we do run a multidisciplinary team setting where the patient is a clinical examination, psychological assessment. They get an ultrasound of the liver, and everybody gets FibroScan these days. They get the blood test, which are for the liver health. We look at the urine sediment for any complications of chelation, and we get serum copper, ceruloplasmin, and to calculate ceruloplasmin-free copper and 24-hour urinary copper. Neuroimaging, we don't offer it routinely unless there are reasons to do it. Next slide. I want to spend a few minutes on fulminant presentation of Wilson, which is it's can debated whether it's an acute Wilson or it's an acute or chronic liver failure, whatever it is. The point here is that if a patient with Wilson disease comes to you who has got encephalopathy and prolonged coagulation, they have a very high mortality. That's the message. Next slide. And it's difficult to diagnose. In this particular study, which came in 1992, 21 cases of fulminant Wilson disease compared with 193 idiopathic fulminant liver failure, you saw that no survival without liver transplant in fulminant Wilson, while 25% of other liver failures survived. So what you have to remember is that encephalopathy in Wilson disease fulminant presentation is a bad prognostic sign. Next slide, please. What do we treat? There is a problem. So we treat as a liver failure. We try to remove copper if we can, antioxidant and transplantation. I will bring this to your attention with more details. Next slide. So this is a very, very important paper. This paper comes from France. And if you look at in these 17 patients, I want to focus your attention to first 5 who died and the rest 12 who survived. What do you find a difference? You find a difference that the people who survived had penicillamine. The people who didn't survive did not have penicillamine. 1. Some of them had transplantation, 2 or 3, but others survived with penicillamine. So it's extremely important for us to remember later on in the last 2 years that not every person who presents with acute liver failure will need a liver transplantation. They can tolerate and survive with chelation. What you have to remember is absence of encephalopathy. If you look at the column number 4, 5, encephalopathy in admission, yes, the outcome is dead, survive with transplantation. But others, no encephalopathy, liver failure, chelation, they all survive. Next slide. Not many people read this paper or quote this paper, but this is the sentinel paper. Okay. Then copper removal is important. So we can remove a copper these days with lots of devices, like one is next one. Next slide, please. So people believe in extracorporeal liver assist devices. I think Mars can remove copper, but does it really change outcome? That I don't know. We haven't seen it. There are case reports of Mars, but it does definitely stabilize the patient, remove the copper. Some people say can delay the transplantation. It's worth trying, but I will not recommend in somebody who is encephalopathic. If somebody is encephalopathic, you need to consider transplantation. Next slide. So remember the paper from France I showed you that 12 out of 17 survived. So how do you differentiate that who will survive transplantation without transplantation? Because what you have to remember now, when transplantation is available, somebody is in liver failure, this question comes, why not transplant the person? Unfortunately, there are more patients with Wilson disease that are transplanted. They shouldn't be transplanted. They can do without one. But we can transplant because we can do transplant. And with living donor, it's even worse because the donor is there with you. Next slide. So Hisham Nazir, if he's on the audience, I pay my respect to Hisham. He, in 1986, when he was at King's, he wrote this paper with Roger William and Professor Elect Mowat, and they come up with this score, which became known as Nazir score, where they looked at total serum bilirubin, AST and INR, and they said if the score was more than 7, you have a high probability of dying, hence you go for liver transplantation. Next slide. So what happened in the next 10, 12 years, people started saying that, they are having a survivors without transplantation spontaneously. So in 2005, we had more patients, because this paper included adult and children. So we revisited it all, included children only, and added more patients. And then we revisited the score, and we found that the predictive mortality with this score, likelihood ratio was 8.7, positive predictive value was 72. So there was some room to improve. Next slide. So with increasing, so what we did is with further diagnostic tests that were statistical methods, we put all the data. And what we realized that white cell count was coming as a variable. And I think, as we know, acute liver failure is a syndrome. It's a multi-organ failure. So white cells is a marker of SIRS, systemic inflammatory response. So, and that is also important in acute liver failure. There's a lot of SIRS response, which lots of PAMPs and DAMPs and BAMPs, if you have heard of those molecules these days, that get activated. So white cell count became a significant parameter. So we come up with these parameters. There are 4 parameters with value ascribed to 5, ascribed to 0 to 4. Next slide. So we evaluated this score prospectively then. Next slide. Mustafa, next slide. So if you look at the area under the receiver curve, we find that, all these parameters, if anything, white cell count was coming higher. And they were all had values in excess of 0.8, 0.9. Next slide. So if you do the univariate and multivariate analysis, we've come up with this index of 11, which took the likelihood ratio from 9 to 22, and negative and positive predictive values in 90s. Next slide. So we did prospectively look at this data, but you have to remember, this is the raw data. And what you find in raw data, we still are not 100%. There are 2 patients who are outliers. There is 1 patient who survived with a high score, and there is 1 patient who died with a low score. So we know where this data is perfect. Next slide. So this data was prospectively evaluated by a group in Europe and in Prague, and they found that this score, what we defined, was applicable in adults also to predict the mortality or survival. Next slide. Next slide. So then came transplantation. This was Tom Stargell. I've just put this fig picture just to respect this gentleman who brought the field of transplantation to where we are now. Next one. And one of his few patients he did with a lot of biliary atresia, hepatoblastoma, but Wilson disease. The reason I'm showing you this slide is even at 240 days after transplantation, this patient had a urinary copper excretion of 974 micromoles. So these patients are loaded with copper and takes long time to get rid of copper. So you don't expect anything very fast. Next slide. So this is a the data which is shows from European data on transplantation, how it has gone, and now increasingly, if the people are using index, I think the less number of patients are being transplanted now. Next slide. This is a data compared to adult and children transplantation. You see more adults get transplanted as a chronic disease, while more children get transplanted as acute liver failure. Next slide. These are the survivals, and survival in Wilson disease is very good, but I want to caution you. This is only 5-year survival. If you take longer, you will lose grafts and patients, which I will tell you why later on. Next slide. The next question comes, can a heterozygous donor be a donor? The parents can be a donor. The answer is yes. This is a Kyoto experience. They had 11 heterozygous donors, and they found that there wasn't a problem using heterozygous donors in these patients. Next slide. This is another important concept. Can you do liver transplantation for neurological Wilson? And it's debated. There was a prospective French study which was presented in ASLD 2 years back, and they showed that people who do not have very advanced neurological disease can get benefited. But the ones with a very advanced neurological, bedridden, very severe contractures, they did have a lot of pulmonary complications in intensive care and died. But those who were not that bad, they did well. So it's important to select the patients carefully, but it's not a mainstream treatment accepted at the moment. Next slide. But if you look at, for example, this is a patient before and after transplantation, and you see the MRI of the brain, which shows spectacular changes, improvement, in other words. Next slide. This is important data I'm going to share. This data has just gone for publication from our group. And what we have done is we have taken our patient from earlier on, from 80s to now 2020. So they are then in their 40s. So they are in the same hospital because we look after them in the adult service also. And what it shows is that as they grow, there are a lot of significant neuropsychological problems. And what we have to be mindful is that patient particularly who presents with acute liver failure has a higher number of having a problems later on. And obviously they require more transplantation, but they have a higher number of psychological complications also. Next slide. So if you look at the next slide, I think this shows mental health and non-adherence. So if you look at the acute liver failure patients, so presented to us, have a transplant or not a transplant, 50% were non-adherent to their treatment, while in the chronic liver disease group, 47%. So if you look at ballpark figure, half of our patients are not regularly taking their medication. Now, this is important. This is the MRI scan data, but what it tells you that MRI is not always helpful. It's not particularly abnormal. Unless you are suspecting a neurological indication, then yes. But if you are looking at otherwise, Wilson disease, we don't find MRI abnormalities. Now, this is what I want you to pay attention to this slide. Next one. This slide shows, no, not next one, sorry, next one. Yes, so this is a slide. So what happened in the last 10, 15 years, I started a Wilson disease clinic, and then similarly, what we have done is our adult young children with liver disease, young people, they are putting them into what we call as adolescent service. They are still looked after by a primary pediatrician with an adult hepatologist, a psychologist, a social worker. So we have a adolescent or what we call is transition team. So if you look at the people who presented to either a MDT clinic in Wilson disease or a adolescent or a shared care team, you find that they are the people they are describing more non-adherence, more mental health issues, more neurological concerns, and more cognitive concerns. Now, if you are not in the multidisciplinary team, they are not telling you this. They have it, but they're not showing it to you. But you will have a problem later on. Hence, the longer term outcome, because this is a lifelong disease, are not going to be good if you don't pay attention to small details. Means asking them, supporting them from all angles. That's when they will tell you, because retransplantation rate is about 20% in the long term. But if you look at the 5 years data, everybody is happy, 100%, 90% more survival. But you need to look at 20, 30, 40 years of data. Next slide. So what is going on in the future? So this is what we are practicing. What is the future hold? So next slide, please. So we are looking at auxiliary transplantation. So this is the Korean group. If they have a small liver, they'll put a bigger auxiliary graft, and they think when the patient liver, the transplanted liver grows, then they can take out the native liver. But there is an alternative approach to it. Your native liver, the transplanted liver, could act as a chelator. A Chinese group have this strategy. They want to put the transplanted liver, act as a chelator, and with time, they think the native liver will get rid of copper, and then they can stop immunosuppression. So that experiment is in progress. Next slide. So auxiliary transplant, there's just a cartoon to show that if you have a bad tree in your garden, if you get a good tree, branch it with a good tree, a branch from a good quality fruit-bearing tree, you can have a tree with 2 types of fruits. So in auxiliary transplantation, the concept is that you can put a metabolic liver, single gene defect, so the transplanted liver will still produce the abnormal normal protein. Next slide. And this is a real life from a group from Korea. They have done this in the Wilson disease patient. Next slide. Next. Then there is a lot of work going on before slide. One slide before, please. Going back, go back. Go back, please, in the one slide. So this is a data on the cell transplantation. So in a LEC rat model of Wilson disease, which is a animal model, if you do a cell transplantation, it can repopulate the liver and can treat Wilson disease in a rat model. So there is some theoretical work discussion we are having whether that should be a therapy for future or not. Next slide. Next slide. So this is people felt that curcumin can help as a chaperone or 4-phenylbutyrate to carry the copper ATOX carrying molecule into the cell. Very preliminary animal work which showed some promise, but it has not been replicated in humans. Next slide. So this is a liver cell model. In what they have done is that in if using antidepressant, amitriptyline, and they've shown that in Wilson disease model, you have a prolonged survival with if you use amitriptyline. It's an antidepressant. It's made into nature medicine, but it hasn't gone anywhere further. Next slide. Gene therapy is something which is becoming more attractive, and there's an adeno-associated virus studies in animal. The data looks very, very impressive. And I thought they were going to start a trial in 2018, but it hasn't started. They approached us long time back. They have got a lot of money. This is a Spanish-American company called Vivid Therapeutics. And I saw the data last year, which is still encouraging in animal model, but they may start a human study soon, but it's not started yet. Next slide. So, ladies and gentlemen, if I conclude that it's a rare disease, 1 in 30,000 incidence in general population. Chelation treatment is very effective. As I showed you, we only lost 2 patients over a follow-up who didn't take their medication. There's no consensus between penicillamine and trientine, but because of the cost, at least in UK, penicillamine is the first-line drug. You can use zinc at your discretion, but remember, 1/3 or 50% of patients have neuropsychological problems. They are not related to copper; they are related to Wilson disease. And liver transplant only when really, really, really indicated. But please try to set up multidisciplinary management teams that will really help the patients and our understanding of the disease as well. And I thank you very much for listening.
Anil, thanks a lot. A great talk and a very useful talk. I think many of the clinicians around are really enjoying that talk myself, and I'm sure there are a few questions here on the, I can see in front of my eyes. If you like me to start some of these questions, Anil, some of them
Sure.
are related, and I have a couple also to add, if you don't mind.
Yeah, sure, please.
Question from Dr. Khalid Al-Ghamdi is just asking, when would you expect improvement of liver enzymes after initiating treatment? I guess in a confirmed, Wilson, who's just outpatient.
I will say if there is a consistent improvement, it takes several months, not days or weeks, months, and about 10-15% will still have abnormalities at 1 year or 2 years.
I will add here just to that question, how would you as a clinician, in a regular hospital, ensure adequacy of treatment and of course, compliance?
So first of all, in Wilson disease, when we start treatment, we are worried about complications of the drug toxicity. So first few weeks, we are looking at minimizing complications of the drug or adverse incidents. We are not looking at therapeutic effect for 3 weeks. Therapeutic effect will come in 2-3 weeks time. So I won't expect liver enzymes to get better, but I would like to see no arthritis, no bone marrow suppression, no proteinuria. Okay. Then if you have got the full dose of the treatment started, then we will do the blood test every 4 to 6 weeks if the counts are stable. And then patient will start showing improvement depending on the symptoms, what they presented with. So most of the patients will have non-specific symptoms, but suppose they have jaundice, which may be hemolysis, that will show very, very rapid improvement. AST/ALT will show improvement, but normalization will take months. If you have abnormalities of INR, but not liver failure, that can take up to a year. But you will see, what you should see is not worsening after 3-4 weeks, gradual improvement.
Is there a rule for, serial urinary copper?
Yes, so that's important observation. So in the origin, so you have a baseline copper to start with. Remember, when you start the treatment, the copper is going to go up. Okay. So once a patient is stabilized, I think if you can achieve a urinary copper between 3 and 5 micromoles, that means your patient is adequately managed. If it's high, that means either the patient is not taking the medication, or he's taken the medication just few days before he is going to come and see you. Or if it's very low, that means he's not taking the medication. Extremely rarely, if you have over-treated him and he becomes copper deficient. In that case, you will see anemia, you will see microcytic hypochromic anemia, sideroblasts, and that will indirectly tell you. That's where the value of non-ceruloplasmin bound copper can come into the light. If you have very low non-ceruloplasmin bound copper and very low urinary copper, that means your patient is copper deficient. If you have high free ceruloplasmin and high copper, that means very likely patient is non-compliant after some time. So if you can maintain your between the normal 3 to 5 micromoles, and the word of caution, not stopping penicillamine before. So there are two protocols. There's an adult protocol where they stop it a day before and then they measure it. We don't stop it, we continue. So what it does is patient doesn't get spooked, if they're going to do this test, they may start taking differently. So we just continuously, without telling them, they say, can you bring a copper when you come back next time? So we do it on the medication, and our paper, which is just gone for publication, that shows that the therapeutic levels are around 6. At that point, 4 to 6, and that's when we are not having side effects of drugs or copper toxic deficiency, and the liver functions are normal and patient is asymptomatic.
A third part of the question, as a clinician, assuming you are seeing the benefit and the normalization of liver enzymes and there's no history to suggest non-compliance, do you assume or you expect your patient not to have fibrosis or progression of liver injury?
So if the patient is copper in the copper balance, means they're taking 2 to 5 milligrams of copper, 2 milligram, 3 milligram, they're eating diet every day, that have excreted. If they're excreting that, we do not. So the reason I say that is because with fibroscan, the data is not there yet to answer your question, because repeat biopsies, when they're done, they're not very helpful because they're in very short intervals. But fibroscan data will be relevant. But if you look at the clinical data, the people who have managed, so we have patients in their 40s now, and they don't have any suggestion of portal hypertension or fibrosis on ultrasound scans and blood count. So we assume getting a good copper balance should look after fibrosis also.
Great. One more question by Dr. Al-Ghamdi. If there is enzyme elevation while you are treating these patients, how do you interpret this information?
So obviously, if we have to see, these patients can have other causes also. Nothing stops them getting a hepatitis or intercurrent infection or another drug. So we will ask for those things first. Then we go for compliance. Then we, depending on the severity, if the AST ALT is elevated, it's very likely what we have found is there's a non-compliance issue. Sometimes they can get hepatitis E, we had hepatitis A, we have adenovirus, they can come with intercurrent infections. And the next worrying thing we are getting now is obesity. So if they're getting NASH on the top of Wilson, that is becoming more of a problem. And we can't differentiate whether it's a NASH or it's a Wilson disease abnormality. So this is becoming now a more difficult thing, yes.
Okay. One more question is asymptomatic patients who are picked up on screening. I assume mutation analysis. I'm going to put the scenario because I'm just throwing the genetic testing confirmed mutation in a family member, then on a sibling who's homozygous or compound heterozygous is there. Now, is the disease there? Is this patient Wilson with normal liver enzymes, and you have not done more than that?
So we will do a bit more than that. If the liver enzymes are normal, ultrasound we'll do the urinary copper. We will do the baseline without liver biopsy. Okay. If the urinary copper is elevated, then we think he has Wilson disease, and we will start treatment for this patient. If the baby, so now we are seeing newborns diagnosed with Wilson disease. So we have a family who had a Wilson disease, and they get a neonatal screening done, and the baby is positive. So we, without much evidence, we have accepted 2 years of age. And you believe or not, there is a child I have in Qatar, and who was diagnosed at birth with genetics, with mutational analysis. We waited 2 years, but just before 2 years, she had become abnormal liver test. I started her on zinc, thinking, this is the best drug to have. And now she's 7 or 8, and she's on Triantin. We couldn't control her with zinc.
When you go to the Leipzig criteria, a score of 4 comes with a positive genetic test. And this is the minimum acceptable for making a diagnosis. Yeah. So, theoretically, following the Leipzig criteria, only a genetic test can make the diagnosis.
Yeah. I think what is not said there is that you have a reason to put Leipzig criteria. That means you are suspecting Wilson.
A family screen, I guess. I'm talking about a family screen. So now it's like exactly like celiac disease. A patient who will be positive with normal biopsies and latent celiac disease. So is Wilson behaving the same way? If you wait too long, you are going to lose, an important time.
No, so this is important. As I gave you an example, this 83-year-old female. 83 years old female, she was admitted for something else. She lived her life. But if she had a genetic test at the age of 2 or 1, she would have been positive. So we need to put some more markers before we just treat genetics. Now, there are gene modifiers. And I gave you an example of this girl who at 2 years of age had abnormal liver enzymes. We were going to start because this child had the same mutation as the sister has. So there were 2 severe disease-causing mutation because sister had a liver transplant. But what we have done in others is when we haven't seen a scenario so far where urinary copper was normal also. We will not treat a person if the urinary copper is normal. We will keep testing the urinary copper every few months, 6 months.
So the question then, in a patient with a positive history confirmed Wilson in a family member, then what do you do first? Maybe the urinary copper for the siblings rather than the
genetic... Yes. So we do everything. We do ceruloplasmin, urinary copper, KF rings, penicillamine challenge. Okay. And if any of these become abnormal, then we used to do liver biopsy, which we are increasingly not doing. But in our experience, all the siblings that we have screened and have found mutations and they are homozygous, they have one or other abnormality.
Good. So which is interesting because we face this scenario. A father has been diagnosed and we have 3-4 siblings and we have done the tests and they are otherwise fine, they are normal.
So if they're fine, I think they need to be careful, monitor them, and we will not leave them alone. We won't say that you are okay. We will say we don't have enough reason to give you this toxic medication. If you want to, you can start them on zinc if they tolerate it. That may be a scenario to use zinc because zinc is not toxic, in other words, bone marrow, renal, or other toxicity. But in our experience, we haven't seen it yet. It will come one day, then I will call you.
Yes. Another question from Hadi Kureri. In acute liver, I'm just reading the question as it is, so to get the right message. In acute liver failure, hemolytic anemia due to Wilson disease, do you suggest plasmapheresis?
You can do whatever you have. So what you are trying to do is getting copper. It's a non-Coombs positive hemolytic anemia. So it's not immunological mediated. What it is so it's a hemolytic anemia because direct copper toxicity. So you can do CVVH, you can do plasmapheresis, you can do Mars, whatever you like. We believe in CVVH is the least expensive because plasmapheresis wouldn't give you much benefit. It takes you big molecules out. Okay, it's not an immune mediated disease. And what I have to remind everybody is that why does some patient with liver failure get better without transplant? Because there is a regeneration of the liver. And that regeneration is depending on cytokines that are going to start the regeneration cycle. With plasmapheresis, you are going to suck every single important protein also out. So we recommend only plasmapheresis for when you are looking at immune-mediated injuries. But in a non-immune mediated injury, we think CVVH will be enough. You will get the copper out that way. Or you can use Mars if you want to use that.
We have a couple of questions that were answered, which is managing asymptomatic, kids picked up on screening from Dr. Qabandi from Kuwait. and you know, our
hi Bafa, how are you?
Yeah, you know, Bafa is also another senior staff, you know.
Absolutely, yeah. How can he?
Yeah. So, and see, one question from Dr. Dafar Shehri: when to say the patient is having over treatment, and how can you manage such cases? I guess we are, I mean, overdoing things, you know, for a Wilson.
Yes.
Are we doing?
Yes, we can. Obviously, if patient is very, very careful, they don't touch anything copper and they're taking medication, they can. So what you find is that when you do 6 months copper test, you find liver urinary copper going down, your serum plasma serum free copper is low, and you can have microcytic hypochromic anemia with sideroblasts. So that is a scenario where you're looking at overdiagnosing, overpopulating the patient.
Do you measure serum copper? Does it give you an indication?
In this, it's what you call as serum free copper. So there's a formula which can calculate free copper from it's called non-ceruloplasmin copper. You can calculate. It's a rough way to do it, but there is another way people from France have recommended is called transferable copper, and that is transferable copper. So they call it, you know, that there's a flux between extracellular compartment and the intracellular compartment, and they call it transferable copper, but nobody else is able to replicate it yet in the world.
Is there a true risk of really reaching that stage of, you know,
no, theoretically, yes. I've seen once, yes. That means excess copper excretion, yes, can happen, yes. Yeah. So you have to be mindful. If your patient becomes anemic and your urinary parameter and serum parameters show, then you should think of, what you do is reduce the dosages, and you will find that patient may start getting better.
One question from anonymous attendees, you know, regarding penicillamine and trientine tolerance. Do patients lose, you know, somehow over long-term follow-up? Do you have to switch or stop medication because of something, you know, either ineffective or a significant complication?
So yes,
yes.
So about 20% of the patients will have complications, adverse incidents because of drugs, and they have to change. So when I showed you 17 patients with trientine, they were the ones who became intolerant to penicillamine. So penicillamine has a higher adverse incident rate compared to trientine.
Even years later.
Yes. So you get skin problems. So when you see adults, they could have very thin skin, cutis laxa, and like good pasture-like syndrome, like nephrotoxicity you can get. But bone marrow suppression you can get. But mostly when they get later on, they used to change because of the skin manifestations.
Abdul Hay Hammo from Dammam here saying hi, Anil. You know,
hi.
And he's having a question regarding transition, you know, from pediatric into adults hepatology. Is there an issue, you know, compliance issues, you know, at the transition stage?
Yes. So the data I showed you, hopefully the paper will come in few months. It's very interesting. We are losing patients later on. They're losing their grafts. They have a high mental health issues. So after we think, you know, as a pediatrician, when they're 16, 18, we are done and we think our results are very good. Just wait till 24, 30. That's when the things start changing. So we insist that they should be looked after in a multidisciplinary team. And if the question is that, do they stop taking medication? Answer is yes. Is it a particular medication? More than one medication is more higher. But once they get used to penicillamine or trientine, then they stick with that.
But this is common to all, actually, you know, adolescents who are transitioning into adults, to all conditions. Now, is there anything unique about Wilson that probably...
Yes. So if you look at the data, I showed you 50% have mental health issues, anxiety, depression, which is not the society, which is not with IBD or other conditions. So this particular disease, now we don't know whether this is a manifestation of neurological Wilson. We don't know that yet. But MRI scan has not been helpful in differentiating. The gross MRI scans are normal. We haven't done MRS. We haven't done functional MRIs, which may be our next project to look into these groups. But it could be a direct toxic effect of copper also, which we don't know. But their incidence of mental health issues is much, much higher than biliary atresia patients or autoimmune liver disease patients.
Interesting. Dr. Basal Al-Shammari is posing the same question that you answered before, which is, I think, a question in many clinicians' mind. Asymptomatic, patients picked up on screening. If you treat, the best treatment. I guess you said zinc. If really
no,
you have.
Sorry. If you are in King's College Hospital, it is still penicillamine. Okay. When you say asymptomatic, there is asymptomatic. Yeah. So that let's be very clear. When you get a patient, most of the Wilson diagnoses are made incidentally these days. They go with a broken finger to accident emergency, you do a liver function test, and you tell them your finger is fixed, but you have a liver disease, and go and see Dr. Idrisi. Then you do a cornoplasmin and you say you have a Wilson disease. So when you do a biopsy, you find fibrosis. So they don't have symptoms, but they have aggressive disease.
Yes.
So this is not the same as a 2-year-old child who has copper exposure for 2 months, 2 years only, compared to 15-year-old who has copper exposure for 15 years.
Yeah.
So that is not really asymptomatic, the wrong word we use. So if you're seeing abnormal liver enzymes and have a biopsy, fibrosis or abnormal ultrasound, that is to me is a patient who has got a copper damage to the liver. But so then we treat them as penicillamine. But there are lots of people in Europe, Italy, other countries, they are going with zinc, which is the new preparation, which is they think it's more effective. The data is there, but what we have to remember is Wilson disease is a very slowly progressive disease. I had 2 patients, started with zinc, Korean patient and Italian. They believed very strongly in zinc, but by 7 years, they were switched to trientine because they could not have normal liver function tests. So I think if it's a patient can take zinc because it's quite a gastric irritant. There is a paper from Poland. They did endoscopies on patient and showed a lot of gastritis and ulcers in these patients. So it is quite a toxic drug. We don't use it, but if parents push us, we will do it. And we say, okay, we'll monitor you closely. I've got 2 patients who have got zinc monotherapy, and they are about 14 and 18, but they both have abnormal liver enzymes. And the family do not want any other drug.
Interesting. I think the question was about those who are picked up by genetic testing in a family screening. But I agree. I think at the end we have to work up every patient who comes to our attention, whether through a family screening or through a symptomatic, presentation. I have a little scenario here, Anil, if you don't mind.
Yeah. Please continue.
Yeah, a little scenario from Dr. Sharifa Al-Dhafari. It's a 5-line scenario. It's a neurologically, affected patient with Wilson, 13-year-old with contractures, wheelchair. He's receiving trientine. His liver enzymes are normal. He has mild thrombocytopenia, INR mildly elevated, 1.5, and he has mild cholestasis. The ultrasound showed normal liver, normal gallbladder, but he has portal hypertension. So I guess he must be cirrhotic. By Doppler, no GI bleed so far. So she's asking, what would you do with this patient, I guess, regarding his liver? Also, vitamin K follow-up in outpatient department. I'm not sure what is exactly the question, but this seems to be a patient with portal hypertension, confirmed Wilson neurological manifestations, whether Wilson related or something else. What would you do in this patient?
Okay, so there are some discrepancies. You said INR, jaundice, portal hypertension, but normal ultrasound. So that very likely ultrasound has to be repeated by somebody different. Or you do an axial imaging, get an MRI scan, that will tell you. It's very likely the liver is abnormal. Now, if this patient is quadriparesis, now the difficulty is, will you offer this patient a liver transplant?
But by age 13, do you expect this Wilson by age 13? I don't know how, since what age he has this neurological manifestation, but he's 13-year-old.
So some patient has accelerated neurological course. They can have it, okay? Now, in this patient, first you confirm the compliance, okay, 1. Second is, if you see the drugs which you are using, trientine, if the dose is right, if you say platelet count is low, that's because of portal hypertension. and whether the dose is adequate or not, because we'll be reluctant to increase the dose if the blood count is low. If you want to, if the MRI of the brain is done or no?
It doesn't say, and they don't say even what age, since what age he's having neurological manifestations. But it's a scenario. It's not clear. It's all what is mentioned.
What is possible for this person is, this person may be a good candidate for tetrathiamolybdate. So tetrathiamolybdate is going to soon enter the. How old the person is? If the patient is an adult, if more than 14 or 16, then there is a possibility of this patient to get access to tetrathiamolybdate. So that may be a good drug for this person. Now, if the liver disease is not that advanced, so as I said in our experience, if you have tolerated medication, then you shouldn't die of liver disease. But if the neurological condition is because of Wilson or not something else, then that means that treatment is not effective. And unfortunately, these patients don't do well in the long run.
Once they are cirrhotic, Wilson cirrhotic.
Cirrhotic doesn't change any, no. Cirrhotic wouldn't kill her. What will kill her is neurological problems. She will not die of liver disease. She will die of brain complications.
I have another question from Dr. Kambal. Again, hi, Dr. Kambal. Do you have a preference for penicillamine alone or combined with zinc? Any benefit of combining zinc?
So we will only use combined if you have a Wilson index of 9 or 10 and we don't transplant them. Now, what you have to remember is when you are giving zinc with penicillamine or trientine, you have to keep 3-4 hours of time apart, 6 hours. And you can't do that if you're doing it twice a day. So you can only do once a day lunchtime dose of zinc and morning, evening trientine. If you do it together, you lose the effect of the both drugs. So it's very difficult to get these drugs together. Unless a patient is awake 3 o'clock in the morning, then 10, then 12, which nobody can do.
Anid, you're talking about trientine and zinc or penicillamine and zinc?
Either. Both drugs cannot be given together. So if you were to use it, we have used it when the Wilson index was 9, 10, we think they are borderline severe, then we have used it. Or the Neurological score was 6, not 7. So very severe disease for a few months. We stop it afterwards because having 2 drugs increases non-compliance. So
and
we
one
don't
drug will
lose
do
it
the
for
job,
long.
probably. Penicillamine will do the job, I guess.
Yes, absolutely. Penicillamine or trientine will do the job. Yes, that's correct.
Yeah. Okay. Is there any preference in cirrhotic Wilson for penicillamine or trientine?
No. Our first line drug is penicillamine. There's no difference in toxicity or efficacy between the two, with whether cirrhotic or non-cirrhotic. No.
Mohammed. Mohammed.
Yes, Abdurrahman, I'm listening to you.
Can you allow me just two questions, quick questions, please?
Can I put the last question from Dr. Hammo? He's saying hi again and
greeting.
Hi. Yeah,
Hammo is my old friend from Nebraska. How nice to hear him.
I think he's a chocolate lover. He's asking about diets. Kids love chocolate. How strict we should be, in diets for
I ask them to eat white chocolate.
That's good. You must love white chocolate, Anil, I guess.
There's no chocolate. There's no cocoa. There's no chocolate in it. It's all just milk and sugar. So they can have as much as they want. Yeah.
Good. Yes, Abdurrahman, please go ahead.
Thank you, Anil, for this terrific lecture. I have two questions. When would you consider weaning off copper chelating agent? I mean, what's your criteria to say, okay, that's enough and we'll stop? This is my first question. Okay, you can answer and then I'll ask you the second question.
Okay, so never stop.
Never stop.
Never stop, because it's a genetic disorder of ATP copper 7B unless you do a gene therapy. Because your copper copper incorporation is always going to be defective. So never ever stop. Reduce. When your children are doing it, they grow by age and their weight keeps going up. We don't increase the dose.
Okay.
So the dose relative to weight will go down with time.
Okay.
When they are big children, then you can stay for a gram of penicillamine a day, maybe maximum, or 750. Okay, but we don't proactively, or you're having a copper deficiency or side effects of the drug, then you can reduce it, but never stop.
Second question is a 14 years old child with neurological impairment, I mean predominant neurological impairment, but slightly elevated liver enzymes. Would you manage different from a child who is having only just liver predominant Wilson disease? Like in terms
No.
Not.
It will be the same treatment.
Okay.
It will be, there is no difference, because if you look at the Walsh data, he used penicillamine in all, Brewer used trientine in many, Dutch group used zinc. So there is no differentiation between the two. There is a slightly higher incidence of worsening of neurological symptoms on penicillamine. But then the catch there is to start slow and go slow. Start low and go slow. That's the word I would use.
Thank you.
Anil, one small question. Can you do without a liver biopsy when other criteria, are there,
Yes, in the modern times, yes. Previously, we always believed in it. But if you have mutations, if you have abnormality of liver enzymes, your copper, penicillamine, you've excluded other conditions, then yes. But in 6 months, if things are not settling, then you can do a biopsy just to confirm it.
Great. I have a couple of questions there also, somehow came in the middle while we are talking. Let me check if they are really truly not repeats, showing as repeats. Yeah, no, we don't have that's it. That's it. But Anil, another question. We as clinicians facing patients coming in the outpatient clinic referred for liver enzyme elevation. We don't know when, for how long. The patient otherwise is doing well, no other synthetic dysfunction. And typically we wait for 3 months for this kind of persistent elevation, okay? Are there other criteria that pushes you to do a workup faster than, than waiting than the 3 months?
So no, so that is an adult, historically adult 6 months, acute hepatitis continues. In children, we don't. So if you send us a child, first abnormality of liver enzymes, if it's not a viral hepatitis A, then we will do the full workup, autoimmune, Wilson, all the other conditions. No, we will not wait 3 months. No.
You're not overdoing things for acute, non-specific, mild elevation of liver enzymes?
No, so depends, a mild, specific, acute is different. So if you have a AST of 70, 80, okay, then you do certain questions. We still do penicillamine, so let me put it different. My belief is try to exclude a treatable condition. Okay, because that treatment, if delayed, can harm the child. So treatable conditions are Wilson disease, autoimmune hepatitis, viral hepatitis C. If you exclude these, then if you're working with a rare syndrome, even if you delay by 6 months, 1 year, it's not going to change anything. Yes. But we will not delay the diagnosis of Wilson, autoimmune, or...
Yes. What I found helpful actually in my little practice, we were lucky to have the FibroScan available, to us. So I add FibroScan at the very beginning of the, first encounter. If the FibroScan is normal, that's a little bit reassuring in the absence again of normal total protein, IgG, as normal ceruloplasmin. That's I don't know if this has been before used or not as a part of the initial management. FibroScan.
So we were a bit behind in FibroScan. So we established normal data. So which took us about 5 years, because there is no pediatric normal data first. Then the limitation of FibroScans are the following. In very young infants, it's not very well helpful. In bigger children, the data is limited and you have to be careful, inter-observer variation, etc. But if it is a 10 or 11 score, if the score is low, that's good. If mild fibrosis, it doesn't tell you. If it's cirrhotic, it's abnormal, but in between, it doesn't give you that much value. So if you have a completely normal FibroScan, that's reassuring. If you have a very abnormal FibroScan, then your ultrasound scan would have picked it up by then. But in between, that sensitivity is not there yet.
Oh, great.
But we use it. We think we are still learning. We don't use it in clinical practice. We are still collecting the data.
Yes, that's great. Anil, I have a question, probably the last one to go. I want to have rest and have dinner.
No, I'm okay. Please continue. Yeah.
Okay. We have from Dr. Ali Salman. What if a patient has a side effect of penicillamine? Do you switch directly or slowly? You mean to another chelating agent? How do you do that?
Always slowly. In chelating agent, there are two different ones. if you have to stop penicillamine because of serious adverse effect, you stop it. Let me tell you something. The patients will not decompensate, die in days or weeks. It takes about 6 months. If somebody stops penicillamine today, it will take them up to 4 to 6 months before they become sick. So we have that time. It's anxiety on our part. Oh, if I don't give it one day, what will happen? Nothing. You have to wait.
So the switch will be over how many days or weeks?
3 weeks. 3 weeks.
3 weeks, huh?
3 weeks.
Yes, yes. Great, great. We had great audience. Actually, they are really, having so many good questions. And Anil, I appreciate Abdurrahman. I don't know if you have any words, but we really thank Supi for their support, and Anil for having the time and really giving us that time to share with us your expertise in the field of Wilson. And again, appreciation to the whole group, that sat for those an hour and a half listening to this great talk. And I leave it to Abdurrahman to say anything to close the session.
Thank you.
Thank you, Anil.
I think you finished it already, Muhammad. Thank you very much, Anil. Thank you very much. Inshallah, and we'll see you in the future.
Thank you. Look, I think I was telling Dr. Idrisi, it was easier to fly to Saudi than getting this set up on the phone.
I was about to pick you up from the airport.
Yeah. I look forward to seeing you soon. Thank you so much. It was very nice to interact with you.
Yeah.
Thank you. Bye-bye.
Thanks for the audience and thanks for you. Thanks.
Stay safe. Thank you so much.
Goodbye.
Good to see you.
محمد.
مع السلامة.
شكرا محمد. الله يعافيك.
الله يعافيك.